With the ever-increasing collection of data in the NHS, it scarcely seems to be out of the news, whether it's about the survival of a children's heart surgery unit or high mortality rates at hospitals and organisations around the NHS. Clinical data is at the heart of this. But outside of those big events, how can clinical data influence the way in which we practice medicine and we deliver services? I've got an expert panel here of people who are trying to change that within the NHS. Starting from my left, we have Phil Koczan. He's a GP and Chief Clinical Information Officer at UCL Partners. Dianna Scarrott, who's Public Governor of UCLH NHS Foundation Trust. Daniel Ray is Director of Informatics at University Hospitals Birmingham. And on my right, we have Paul Altmann, who's a consultant nephrologist and Chief Clinical Information Officer at Oxford University Hospitals. Simon Eccles, who's a consultant in emergency medicine and former medical director for NHS IT. And Martin Bardsley, Director of Research at the Nuffield Trust. I'm going to start with you, Simon Eccles. Some clinicians may say we've been treating patients perfectly well without good quality data. Why change?
I question the premise that we've been treating people perfectly well. I would suggest that doctors have certainly been treating individuals to the very best of their ability, and that's marvellous, but we've been doing it without the intelligence that other industries would take for granted on how best to treat their patients. Many of our decisions are either made at an individual patient level on the basis of too little information. I was on call last night in our A&E department. One of my patients regaled me with his relatively long medical history, and I admitted him overnight for no other basis than I couldn't verify aspects of that, and without being able to do so, needed to bring him in. That's an insane waste of resources and is not in his best interests. But we also treat people with medications that are effectively only being tested on the say-so of companies that we don't always trust. I read the BMJ avidly and have been keen on this week's issue on statins. Are they in an individual in front of me's best interest? It may not be a discussion for an emergency physician. It's certainly a discussion for medicine in general. So if we are going to make better decisions, we need to do so on the basis of the kind of data-based intelligence that the rest of the world takes for granted.
Thank you. Phil Koczan, primary care, are we in a better position than secondary care in terms of the data we have to treat patients?
I think one of the problems in primary care is that we've had IT systems for probably the best part of 20 years. And as a GP, I've been a GP in the practice for 20 years, we've been paperless through the whole of that process. So we have an absolute mass of data within our systems. The problem is turning that data into useful information and being able to share it with others. So that when I refer a patient to the hospital, we end up usually either printing it out or in some way attaching it to an electronic message which probably gets printed out at the other end. So we make great use of our own systems, but the data is stored in silos. We've got wonderful decision support systems that tell us what medication we prescribe for the patient, what are the potential interactions. So if a medication starts in hospital, we've got no way of getting that into our system unless we enter it ourselves. So I think there's a lot we can do for joining the silos of data.
Great. Dianna Scarrott, can I just come to you? Do patients feel right now that we've been treating them perfectly well without good clinical data?
Well, as an individual patient, I've got an interesting left eye, and I know there's masses of data, and I'm going to have the fields tested on Monday, and I know it's going to sort of show whether it's different or not. So, I mean, I think, there is a lot of very good practice out there. Collectively, I mean, it just must be that we should be using data more. I mean, every other industry, everybody in work is using data, and we've all got KPIs, and we've all got objectives and targets and all that stuff. And really, healthcare has to have the same sort of discipline. And actually, it's more satisfying to work in a situation where that sort of thing is going on, and you have some sort of measure of how well you're doing and whether you can improve things. So, I mean, I don't think it's a sort of situation where I don't think it's a question where there's a sort of opposition to it. I think everybody's sympathetic to the idea. I'd have thought.
Excellent. I'm going to come to you now, Paul Altmann. Have you been treating patients effectively without good clinical data?
I hope I have. And I think that Simon was saying, it's the aspiration of all clinicians in the UK, I hope, to treat their patients as well as they can. That said, it's very clear that there are occasions when we drive through the amber light, if you like, and most of the time the safety net that is in place, that the NHS has put in place, prevents errors from actually having any serious impact on the patient. But occasionally we actually do go through the red light, and whilst sometimes you get away with it, again because of the safety net, that's not always the case. And I think there are clearly occasions when not having the right information about your patient, or the right population level information about the particular condition, that patients will be poorly treated or occasionally come to harm. And that's something that we really must strive to prevent.
Martin Bardsley, do you think we can even say we've been treating patients well without clinical data?
Well, I don't really know if we can, actually. So as my view is that a lot of people are talking about outcomes and the importance of looking at health outcomes over a longer term, whether or not patients are getting better. Yet very often our information systems only capture a very specific episode in care. And what we want to see, and what we can see in the more sophisticated systems, is the way that these are put together to show a patient history within an organisation and over time, to really understand whether or not the care we're giving is delivering those results that we want to see. And good clinical data is absolutely critical to understanding that, and for developing comparative models to research that and understand the treatments that are giving the best results.
Absolutely. Okay. Daniel Ray, you're at slightly the other end of the process. You're the creator. You're the creator of data. I mean, is it fair to say that they haven't, that we, as clinicians, don't have enough good clinical data, or is that actually flawed?
I think it varies a lot from hospital to hospital as to the extent of clinical data. We're in a fortunate position in Birmingham in that we have an awful lot of clinical data available to clinicians that's captured at the point of care, which I think is really important. Much more than most, but we've gone one step further than that in the way in which we replay the data back to clinicians. In answer to your question, I don't think that the average hospital does have enough clinical relevant data available to clinicians. I think that the opportunity is there now to grasp to do this. And what we found is that when we actually replay the data back to the clinicians, that's what's meaningful and relevant to them about the outcomes of their patients, they engage in it much more when we make it relevant to them. I printed out the NHS data dictionary for inpatients, the main mandatory collection from hospitals in 1998 in a red folder, and it sits on my shelf and I still use it today. And there's an awful lot of discussion over the last few years about what metric for outcomes can we develop with the data we've got, not what is the right measure that we need that we should be using to assess the outcome of our patients.
Very good. Phil Koczan, if clinical data is really so important, how are we going to make it? How are we going to make sure it makes a difference? How is it going to impact patient care directly if we use it more effectively, as Daniel's suggesting?
I think one of the key points is that we are awash with data but have very little useful information. So I think really picking up on the points that Daniel made about the ability to feed that back to clinicians. How can we spot patients that are falling through gaps in care? How can we make sure that as a GP I'm providing the best evidence-based care that I can, and I'm not reliant on information that I was taught 20 years ago when there's something more recent in for example, BMJ, other literature that I just haven't read and assimilated or applied to that patient. So I think there's a great opportunity for linking everything together. But I think at the moment, we're in that space where we think we're doing a good job, but A, we can't prove it, and B, there are gaps.
Sure. Simon Eccles, you were the medical director for NHS IT for a while, and one of the big aspirations was to do many of the things Phil was suggesting there. What do you think were the real challenges, and what do you think were the real barriers in that process?
So I'm going to tackle it from two perspectives. One of the challenges is agreeing which bits we standardise nationally. Are we actually going to mandate some things are identical everywhere across the country? The identity of patients, the identity of staff, particularly for staff who are transient or move across multiple organisations. Pathology. I think to patients' surprise, pathology is far from standardised and is unique laboratory to laboratory in a way that is clinically dangerous in some cases. In the second decade of the 21st century, I'm not clear that's a good idea, and I think that's probably a government responsibility to clear up. Some of the barriers have been a huge reluctance to get over the hurdle of starting this process off. There is quite a barrier to do it. As Phil rightly points out, GPs are way ahead of most hospitals. In many hospitals, data is entered electronically in systems that are individual to that specific piece of care, up to 400 systems in a large teaching hospital. Again, that can't be the best way of doing things, but many clinicians do regard their own care as their unique fiefdom that shall not be trampled on by anyone else. And can I just have one more aspect to this, which is if we get it right, we're going to change the paradigm of medicine. Because right now, what little data we have emphatically belongs to the clinicians. Much of it's on paper, and across the front of that is written, property of the hospital, do not remove under any circumstances, you will be shot on exit. Rather than the data belonging to the individuals about whom it has been written. So you can find out more information about the car you're planning to buy or the holiday you're planning to go on than whether the particular operation you're likely to have is the best one for you and the outcomes of the surgeon who's going to undertake it. That can't be right.
Paul Altmann, are you fixing these problems in Oxford?
That's certainly our vision. I think, I mean, you've touched on this issue of fiefdoms, which leads very well into one of my sort of big missions, which is to do away with all of that and remind people that they are here to look after their patients, and it's the patient that comes first. The bigger the organisation, the easier it is for those fiefdoms to flourish, sadly, because big organisations are difficult to control. And I would say that that we have our fair share of fiefdoms, and just trying to corral that is quite difficult. So, without being too specific, I can tell you about a conversation that I've had in the last 24 hours about a desire to put in an electronic solution to do something that is important right across the trust. But amazingly, rather than looking in at the trust strategy, these guys went and looked at something in Australia which they would like to put in as a standalone system, adding yet another silo of information. And when I talk about, so, you're going to ask clinicians to record allergies in your system and in our system as well, because otherwise it's not safe. They agree it's not going to happen, which means that one or other system won't be updated when those allergies are updated in one or other of those systems. And that's dangerous. It's so dangerous that as the person who's got the clinical safety hat on for informatics, I wouldn't be able to sign that off. I would refuse to sign that off because we would be introducing clinical risk. And I just keep bringing people back to the idea that, a person is born. During the course of their life, they may have periods, hopefully very few, when they need some medical care. A lot of the time it's entirely episodic. Sometimes it's chronic for a period of time or forever, and it's when it becomes chronic that all of the organisations and individual clinicians that are involved with the care of that patient need to be able to see what everybody else is doing. And that is a real challenge when you've got 400 systems.
Thank you, Paul. I just wanted to bring in Dianna Scarrott there. So from a patient's perspective, and also, and in your position as a governor, if you heard that UCLH had lots of disparate systems which didn't talk to each other, what would your reaction be to that as a patient?
I've become very convinced that data is what drives improvement, and actually quite simple data, simple data, sort of ward level, and people counting things and counting them better and all that stuff. I mean, I'm quite new to this stuff, but I know doctors talk about this all the time. But I completely believe it, and I'm very convinced by it. So yes, that does need integrated systems and simple systems and accessible systems, and they are fundamental to the improvement of care. And people talk about culture change, and people get all sorts of, after the Francis report and all that sort of thing, they talk about culture endlessly, but actually, if you could get everybody sort of committed to using data and seeing it and enjoying it, then that's how healthcare is going to improve, I think.
Daniel Ray, do you see patients benefiting directly from the way that you've integrated and standardised data within UHB in Birmingham?
Yeah, so in the 1st of July last year, we launched a system called My Health at QEHB, which pulls all the different systems that exist within our hospital together. So our documentation, the lab results, the prescribing, all into one place. So it picks up on what was just said and puts patients fully in control of their record. They can add data to their record, and the transparency that's come about has been incredible. My mom is a user of it. She had breast cancer. She finds it incredible that she can sit at home, read her letters, and her medication before she goes into clinic. I had a consultant phone me up the other day who said he was amazed about a patient that came into his hypertension clinic with a wireless iPad, who knew more about all of the results in the letter than the clinician did. And he was slightly late for his clinic, and he was sort of rustling around trying to find look at the results. And the patient said, well, I've got them here. You can have a look at them here. And the dynamic's been fascinating, the way in which it's changed. We've had some patients that have said, I actually believe now what the clinicians are saying about me because I can read it in the letter, that goes back to the GP. One clinician said before, whereas if a patient was sat in front of him and said that they were taking their medication and he just didn't think they were, he'd just write to his GP and say, this chap says he's taking his medication, but I don't think he is. But now, because a patient can read that, he's actually got to tell it. I know you're telling me that you are, but I don't think you are, and I'm going to tell your GP that you're not. So it's been a fascinating change in dynamic. We've just targeted long-term conditions at the moment, but we plan to extend that above and beyond. And the learning has been incredible. From what country do we lock out that somebody goes to around the world if they're on holiday, to the level of access that you put upon it in terms of the security. The learning's been incredible.
Great, thank you. Martin Bardsley, are there any other ways in which we can see clinical data being used to benefit patients, and how do you think we'll see that?
From my perspective, I don't work on the front line, I work with the bigger systems. So for areas like performance management, performance assessment, the nature of clinical data is absolutely critical. Not so long ago, a couple of months back, the Nuffield Trust was asked to produce an analysis of whether or not we could devise a system of ratings for health and social care providers and what that system might look like. And we duly produced our report. But one of the most critical factors, if you like, limiting the quality of those performance assessments was what we understood about the detailed clinical care that was happening. As Daniel mentioned earlier, many of our systems are really very crude. They work on the lowest common denominator between hospitals. And we're really missing a trick in not understanding some of the detail that's really important if we want to get a decent description of performance and understand different sectors and different areas of healthcare. And I think it's a very long agenda nationally to move us into the right space.
Very interesting. Phil Koczan, many clinicians are highly suspicious that clinical data is there as another stick to beat them with. What do you think of that? Is that a view you share?
I think the problem is at the moment we're being beaten by data anyway. And that's often data that's collected remotely from us and fed back in such a way that it's actually quite difficult for us to believe that original data. So it may be several months old, gone through several transformations.
Mm-hmm.
And one of the examples that we've seen very recently is GP prescribing of antibiotics, and showing that there are some areas that where GPs are supposedly prescribing very well, other areas where GPs are prescribing badly. The problem there is that unless you can actually link it with a diagnosis, so you can work out is that prescribing appropriate or not, it's actually quite difficult to learn as a GP where have I done wrong. So some of the work that we've done has been around COPD and looking at patients with specific care in COPD. By capturing the data at the point of care, by feeding that back to clinicians in a useful way where they can see their data for their patients and where they need to improve, we can actually drive that improvement. So we're showing the gaps. It is something that could be used as a stick, but equally, most clinicians will engage with data that they believe and they can see how they can improve.
Daniel Ray, what's your experience of presenting clinicians with data which they might be a bit threatened by?
I mean, in my experience, certainly what we've found is that if you present them with really clinical, relevant, meaning data that's important to them, if there are problems and issues with care, you don't need to beat them with a stick, because they'll take on the challenge of sorting out whatever the care delivery problem is themselves. I'll give you a couple of good examples. In cardiac surgery, it's the clinicians know better than I do, but it's well known fact if you come in on a beta blocker and you get that on the day of surgery, you've got a much better prolonged expected, the prognosis is much better. And there's the rule of the 85%, so what proportion of patients are getting this? And the answer before we measured it was it's 100%, of course, it's 100%. And then you look into it, and largely with these things, it's sort of 82 or 85%. But now, they'll either cancel the operation or they'll embarrass the registrar, and they'll say, you've got to phone the patient up and get them to come into their GP surgery and get this drug prescribed. And if you make them clinically relevant, one of the big drivers that we pushed on in the hospital globally across the organisation was omitted antibiotics. So if you've got a high raised white cell count of over 10 and 2 or 3, potent are missed in a row, it's something that you can't argue with, and clinicians would want to address that. And it's not about beating them. I think it's about, holding people to account to ensure that, the care that patients get is the right care, and that's what they should get.
Paul Altmann, do you beat doctors up with data?
Try not to. I mean, there's no doubt that it can appear to be quite a nasty stick if it's presented badly, and I think a lot of it is in the art of management. And I'm someone who often talks about making the stick taste more like a carrot. And I think most of the time you can do that. And it is about how you engage with the service. I think there is a big difference between how you do that within the context of a general practice and a 15,000 employee organisation such as a tertiary care specialist centre. And part of the problem is the worry that people have, that underlying suspicion that what the electronic system allows management to do is to watch your every step. And that's absolutely true. It makes life incredibly transparent. And I mean, it's the same argument that I have repeatedly around identity cards. If you've got nothing to hide, then why worry? And if you've got something to hide, then it's a really useful way of getting bad practice out. And we're not terribly good at weeding out bad practice. We're very good at saying what good practice should be, but generally I think the NHS needs to be a lot better at spotting bad practice and getting on top of it very quickly.
Thank you. Martin Bardsley, just from the outside looking in, the use of data to influence clinical behaviour, what do you see are the challenges there?
Many. Can I also mention the GP systems as well, though, as an outsider? I think one of one of the really positive things that's happened over the past 20 years has been the development of those GP systems and the way they become a right hand, a tool for everyday primary care practice and for clinical data collection. And some very positive messages from that sector that I guess we'd like to see reproduced in other areas.
Very good. Dianna Scarrott, what do you think is the view about how we use data to influence frontline staff without putting them under threat, putting them under greater pressure than they already are under?
I think for most people in work, and this is not about healthcare specifically, it's just generally, information about how you're doing is useful, helpful, and in its and sort of coercive without actually anybody having to coerce. And most people respond to it. And I think we shouldn't sort of get too worked up about, if the data is meaningful and seen as properly collected and of decent quality, then it's going to influence people. You don't have to do anything more, you just make it available. If it's not of good quality, then it's got to be sorted out, and there has to be a discussion about that and about improving the quality of the data.
But to an extent, it does matter how it's done. I suspect most of the audience will be familiar that recently, nationally, we've had difficulty hitting the 4-hour target for emergency care in A&E departments. The Secretary of State made an announcement that help must be provided, and a letter was sent by NHS England, which essentially the only single recommendation in the letter was that hospitals should be fined if they didn't do well enough, and that it was the responsibility of CCG's commissioning groups to ensure that they did so. That triggers a behaviour in clinicians in hospitals that is, I would suggest, counterproductive. It makes hospital clinicians extremely passive in their reaction. So if we get this data wrong, which I think is part of your question, it ends up with, once again, the entire NHS looking upwards to be told what to do. And I think that's lethal. I think that's hopelessly outdated and inappropriate. If we get it right, the data becomes a real tool for individuals to improve their own practice because they can peer benchmark, they can see good practice, they can understand if they're bad. If I'm one of the bottom decile of emergency department consultants in London, I will do something to improve my practice. I suspect virtually every A&E consultant think I'm above average, which clearly can't be true. But data can be incredibly helpful when it's in real time, it's clinically relevant, and the individuals who are looking at it have bought into how it's been collected and how it's been manipulated. And that is not what we are doing at the moment in the NHS. So I think we are right to be nervous about this.
And of course, when Bruce Keogh was asked whether he took action on poor data in Leeds, he said, indeed I did. So it's important that we see the data coming out as being valid and something that you can make a good decision upon.
Absolutely, subject to it being useful. So the cardiac surgery data, yes, absolutely. But many of organisations looking, that's the target I'm most familiar with, the 4-hour target, will be spending something around 2 to 3 man days per week of clinical and senior managerial time validating and manipulating and looking at and playing with that data simply to measure a single time target, which has a tangential relevance to clinical care. If you're good at it, you're probably offering better care, but is not fundamental to an individual patient being treated better. We need to get much, much better at this and devolve it locally so that individuals are using the data because they want to see how they're doing.
Thank you very much. I'd like to bring in some questions for the audience. Now we have a question from Tom Smith.
Thank you. Tom Smith, Health Research Authority. We've spoken so far about how clinical data can improve results for patients directly. But thinking about the transparency agenda within medical research, how can clinical data improve research for practitioners, for patients, and for prospective patients in future?
Martin Bardsley.
Yeah, I think this is a really important area, and I think things are beginning to happen. And if you like, the better the bedrock of clinical data, the better the research that we can do upon it. So, for example, we're increasingly finding clinical trials that are using data from operational systems with the right precautions around them to do much more sophisticated studies on a much larger scale than was possible before. So, for example, we've been involved in a piece of work looking at telehealth technology. This is home-based technology, and because we were able to tap into hospital records, GP records, in a safe way, we're actually able to use a sample size of something like 6,000 patients on that, and to do really quite complex risk stratification, a much more sophisticated research technique by using some of these existing data sets. Even so, in doing that, we were limited in part by some of the clinical data that was or was not within those systems. So the better the quality, I think the greater the scope for research and audit. And there's some really interesting examples, say from Sweden, the way that some of the clinical databases around things like rheumatology have developed as both an operational tool for the clinicians, an audit tool to understand practice, and to directly feed into clinical trials at the same time.
Daniel Ray, what's the UHB's experience of using the data you collect operationally to actually do clinical research?
I think that over the last couple of years we've accelerated the use of clinical data in our organisation for research, and I think that has been our recent ability to be able to extract the data that's captured at the bedside, at the point of care. And so when you consider e-prescribing solutions, electronic observation, capture, all of that sort of thing, a lot of the thought is given around procurement within hospitals to how the system's going to be used in its primary use. So how am I going to collect it and use it for the delivery of care to the patient in front of me? And over the last sort of 4 or 5 years in our organisation, we've had electronic systems for about 10 or 15 now. We've really focused on being able to pull that out, link the different systems that exist within the organisation together. So the linkage of data has been really important. Because often you'll get one question for research, but it'll involve pulling in data from lots of disparate systems and being able to link and combine that data set together. So we've seen quite an acceleration. A number of consultants in our organisation now, when they're putting a grant in for some research, one of the most important things that they will consider is an informatician, somebody who's going to be able to get hold of the data, link it and do all the analysis for them. And slowly going are the days where you employ somebody to trawl, bucket loads of paper of the notes to find out who received whatever drug and what was their diastolic, systolic or whatever. So, and gradually that's increasing, and we've got around half a dozen now specialties that are literally employing full-time people specifically to crunch and analyse data for them in relation to research. And I think that's set to continue and will increase.
I'm going to take one more question from the audience. Is there the lady down there?
Okay, thank you. I'm Caroline Jessel from Kent and Medway, NHS England. And I've been spending quite a bit of time trying to promote patient access to records. Over the last 18 months or so, there's been a project going in Kent and Medway on that. And interestingly, it would certainly solve the problem of the patient being admitted just to establish their medical history, because they would have access to their own medical history. Interestingly, the barriers that come up are partly from patients and also partly from my GP colleagues who are worried about being overwhelmed by work. And I wondered what the panel felt, how we could get over those barriers, because I'm sure that is the best way forward.
Dianna Scarrott.
Oh gosh. I live with somebody who's been to A&E a couple of 4 times in the last month, wouldn't have had his medical records, wouldn't have been able to cope with that, wouldn't have been really able to manage that. And there are so many of us who are rather feckless, and I just wonder, I want the I think I want the systems to be there working in the background rather than needing too much.
I think in 100 years' time, I think people will look back and they'll think, what were they all moaning and fussing about? And, of course we've got access to our health records. What's all the fuss about? And then what we experience locally with our clinicians, There was a couple of specialties, perhaps I won't name them, we rolled out to 11 My Health portal that I talked about earlier, and there were a couple of them that purposefully held back because in signing patients up, because they were waiting to see how much communication they got in the other specialties from patients that all of a sudden had access to the health record. And what we actually found was that even the noisy patients who were phoning on a daily basis or whatever, that it actually dropped off, and it actually reduced the amount of contact that patients were coming into clinicians. Because they were able, often the questions were about, what was it that you wrote in my letter last week? Or they'd say something and they couldn't spell it properly, but because it was in the letter, they could look it up, Google it, and understand what was going on. So it reduced.
Simon Eccles, we had a crack at this nationally.
Yes, we did. and so I'm forgive me, I don't know whether I'm personally relieved or not to hear that you're facing exactly the same problem in County Medway, and that we hadn't just got totally incompetent. But there's a small, in number, but very vociferous and quite loud group of patients who regard the electronic holding of clinical information as inherently wrong. I think they need to wake up to the era in which we live. No, this is not compulsory. You say no, live in a small cardboard box and retain everything on paper. Everyone else is going to be electronic. And there are undoubtedly some clinicians who are really vociferously opposed to this, apparently on a wide variety of grounds, but it boils down to workload and money in a way I find difficult to understand. The international evidence suggests workload drops when patients are fully in charge of their own healthcare and have free access to their own health information. They better understand what's wrong with them, they make much better use of consultations, and they have fewer face-to-face contact points because they can access their data in other ways in the meantime, and they can provide email or telephone consultations to answer small queries, particularly patients with long-term conditions. Somebody, and I would suggest somebody nationally, needs to grow enough of a backbone to get on with this so that we cease the argument. It mustn't be compulsory. Absolutely anyone who doesn't want to have anything to do with it doesn't need to. But I would hope it's not 100 years. I pray it's not 100 years. We will rapidly look back on what on earth was the fuss about and enjoy better medicine for clinicians to give because it will be more satisfying, and much better healthcare to receive because you'll feel more in control of it.
Phil Koczan.
Yeah, I think from my perspective, it goes beyond just pure access to the record. I think sort of Simon touched on the interactions between patients and clinicians, the ability for patients to book appointments online, to be able to order repeat prescriptions online. I've certainly had some examples recently where I've had email dialogue with patients and with carers of patients. So one particular example is a patient that sends me every month a very detailed spreadsheet for all his blood pressure readings. I'm able to put that on my system, authorise his repeat prescription, and job done. And if it goes out of a certain range, then you can guarantee that within the week he's there to see me to discuss it. But actually, it works very well for both of us because we only see him when we need to. And the other example was a patient who was heading towards needing nursing home and social care support. His son lives a long way away, and with the patient's permission, we entered an email discussion, which actually saved a massive amount of time. Being able to email referral letters so that they could join the dots with the different services very, very quickly.
Thanks, Phil. Paul Altmann, quickly.
I mean, I think you touched on the areas of resistance. I think that the biggest area of resistance actually comes from the medical profession. Partly primary care having a concern about other people being able to see into their system, and then in secondary care a huge amount of discussion about, so if we stop seeing patients face to face because we don't need to always see them face to face and we do it digitally, which is saves an enormous amount of time and improves the level of care, how am I going to get paid for that activity?
Absolutely.
And of course GPs have crack the how am I going to get paid thing, because they've managed to incentivise lots and lots of things with little payments. I personally am against that. I think we should be there to deliver the best possible care and not have to have financial incentives to do it. I mean, we should be salaried, as hospital doctors are. So that's my little plug. But I do think there is a real issue about how we provide incentives in some way to get people sort of across that barrier, because it's, there are a whole tranche of hospital clinicians who have not crossed that threshold, and they will not accept an email from a patient. And then there are others who are doing it readily and they don't see themselves swamped.
Which leads me on to the next question, and it's about trust, really. It's about how do we ensure that clinicians trust the data that's shown to them, and I'd include patients in that. Martin Bardsley, what's your view?
I think, it's a familiar story. It's about involving the clinicians in the collection and monitoring of that. It's about the data collection process not being an add-on to their work, but part of their everyday activities, something that they need to do their job properly, that it adds value to them, and it's important to them that that data is accurate and that data is right. And I think we need to reinforce the systems that do that, that give benefits to the clinicians, and that improve the quality of data.
Phil Koczan, so primary care, we've been exposed to quite a lot of data coming our way in our time. What methods and techniques would you use to ensure that that is adopted by clinicians in a trustful way?
I think the important thing is about ownership. It's about the ability to collect the data easily, so actually collected as part of routine care. I mean, the sort of 4-hour waiting times that that we heard about earlier, where there's a whole industry around collecting and monitoring data, which actually maybe isn't that important to the clinician with the patient in front of them. So it's about ownership. It's being able to trace back that when you get the data back, you can see, well, there was a problem because of that happened yesterday or the day before, rather than 6 months ago, and being clear what we need to do to improve.
Daniel Ray, do the clinicians in UHB trust your data?
They do now. I think it's what the data is that you're engaging them with on. So I don't want to get too detailed, but it's got to be relevant. It's what we've said before. And the classic, the nomenclature of ICD-10 coding. There's variability around the accuracy, what it actually means. A description seems sometimes not to mean anything to a clinician as it does an informatician, in terms of what you're looking at. But I think as much it's about being able to replay it back to them in an easy way that they understand, that they find useful, and that they really passionately want to use to evaluate the level of care and quality of outcomes that their patients receive. And I think if you do that, then they will engage with it. And we went through a cycle at UHB. We pulled the data out and replayed it to them, and they said, it's wrong. Okay. And then I said, well, can you engage in it? They said, no, because you won't be able to replay it back to us quickly enough. So we did that. And they said, well, we're still not going to engage it really, because you're going to just hit us over the head with it if we don't get it right. So we said, we're not going to do that. We'll establish a unit that's independent from the trust management, which we did, which is chaired by a cardiac surgeon and a number of other frontline clinicians that don't hold management positions sit in that group, and they use the data independently to improve quality and outcomes.
Is there a cultural change that needs to happen, Paul Altmann, in order for this to be effective?
Absolutely. The manner in which the clinician does their work and the manner in which they collect structured information during that process is a significant change in the way they need to behave. And I think that is very challenging for some people who have never thought about any type of structure. I think the other thing is about believing that the data that comes from devices, for instance, that might feed into your electronic record system automatically, or indeed information of the sort which is communication between one clinician and another, where you are handing over some tasks. So I'm referred a patient for advice, I send my advice. Now I can send that electronically. But it turns out that I can send it electronically and it will go straight into the target system. But depending on the way in which that particular system has been configured, I may not have any guarantee that anybody actions that bit of information. Whereas if I send it on paper, I know that someone has to actually touch it, because you can receive electronic information without touching it. And we have to develop some digital way of touching it and being able to prove that it has been touched and actioned. And this is something that as we've moved, for instance, from a paper A&E department to digital, it's something that keeps cropping up. Oh, we did send you a summary, but what happened to it when it got to your end? So there's a whole raft of different behaviours. Some people just have it incorporated into records, some have it held and you have to sign it off. Others will print the digital communication and scan it back in. It's extraordinary. and the delays that some of those processes put in can become unacceptable. So we have to try and standardise, not just on the type of data, but the way in which we handle it, so that we know that we all do things in the same way, and that's expensive, very expensive.
Dianna Scarrott, how do you think we improve patients' trust in data as well as clinicians' trust in the data?
As a patient, I want to talk to somebody. Really, I think I'm not that interested in the data about my stuff. And you know, I've looked at letters that people have had, really helpful letters saying this is what you've got and this is what we're going to do. But I wonder whether they're really intelligible to patients. I mean, I think it's, you know, we have a right to that information, and if we want it, we should be able to get it. But I don't know whether everybody actually wants that much information. They want to be treated like a human being and given careful interpretations and probabilities and things like that. You know, well, actually, this is what we're going to do, and it might work. And some of that is not the sort of thing that you're going to find by trawling through your records. And I think, you know, communication with patients is really important. But I'm not sure that that's the real point of improving these data systems. The point is to give an aggregated picture of what works and that sort of thing to clinicians.
That's a really good point, isn't it, Simon Eccles? That, you know, actually there's an interface here between the data we're collecting and how we're presenting it to patients who are making decisions.
And how we present it to different healthcare professionals. So as we move unbelievably slowly towards structured clinical data from our traditional free text with a fountain pen, I think we're actually sort of going against the grain of the way other industries and other systems are capturing information, and we are 1 or 2 decades behind in an obsession with very pared down data points, and at its worst, I've used many clinical systems that do the drop-down menu and ask the clinician to select from the drop-down menu. There are wonderful stats on how likely the clinician is to go to the second page of the drop-down menu. The 4th page never gets clicked. It doesn't matter what's wrong with the patient. And if you have to open more than one sub-menu, you're in trouble as well. So people end up suffering from conditions of the first page. So I fear if we do data entry badly, we actually make data quality worse. We harm research. We don't communicate well with patients, and we don't communicate well with each other. How do we collect the richness of information, which if any of you have read a well-written clinic letter, there is an awful lot in there that isn't actually the diagnosis or the symptoms, that gives you a real feel for what took place, what you need to understand about it, whether the patient or the clinician, and what perhaps happens next. Other data systems are getting much more intelligent about that richness and how you derive useful research quality coded information. We need to. There is a science to medicine that needs to be treated as a science, but there is also an art and a richness to it that is around good communication, and I don't want us to screw that up in our drive to just concentrate on data. I've seen some super systems that get it right. You type free text, it provides codes, it then plays the codes back to you. Is this what you would like for your coded information? You go, yes, that looks exactly right, fantastic. And I've used some utterly dreadful systems where clinicians shortcut their way through it in a hurry at 2 o'clock in the morning in an emergency department and are recording much worse quality than if they'd just been allowed to scribble. Somewhere between those rests the right answer.
Well, I mean, there is a delicate balance between a highly intelligent system that can interpret with the flow of language, which is how we tend to think up here, and the requirement to make sure that when one of your patients goes to a hypertension clinic, a clinic that deals with blood pressure, and that when that doctor writes to me who deals with difficult hypertension, they remember to put the blood pressure in the letter.
Oh yes.
So there's an element of structure and guidance that we need to have there, which is what I mean by structure,
yep.
As opposed to, the structure that you're referring to, which is all tick boxes and drop downs and radio buttons and everything like that. You can have a very effective blend of both, because when it comes to actually making sure that protocols of care are delivered, you do need some digital prompts.
Thank you, Paul. I'm conscious we're running right out of time, so I'd like to move to the very final question, which I've left a comfortable 3 minutes for. So if we could have the 2-sentence answer, which is what the benefits we're going to see in an NHS which is using clinical data properly. Phil Koczan.
Okay, I think the question, the answer really is around who's going to see the benefits, and I think there's benefits to the patient, greater information about their care. There's benefits to the clinicians, so actually being able to deliver better care to the patients using evidence-based medicine, and I think there's benefits to the managers, actually being able to see how well the system is performing.
Great, thank you. Dianna Scarrott, what benefits do you think we'll see?
Well, the same. Everything. Efficiency, outcomes, just better health.
Daniel Ray.
I'll say something different then. For me, one of the big things would be an addressing of some of the inequality in outcomes that we see in different parts of different health economies across the country. You've got much greater survival rates for some disease groups based upon where you are in the country. And I think if we better understand that with more clinically relevant data, we can address some of those issues.
Thank you. Paul Altmann.
QIP and patient experience. So when I say QIP, everything that encompasses, which is what Phil's talking about. And patient experience, I've been in many hospitals around the world that have no paper now. And it's a completely different feel. And when you watch that interaction between clinicians and their patients, both looking at legible information, it's transformational. It really is remarkable.
Simon Eccles.
I hope we're going to empower patients and we'll get an equality of relationship between clinician and patient, which we have been sorely seeking for some time.
And I think we're going to see a better understanding of what benefits patients are achieving. And I want to see us using that in more informed debates about how services are delivered and how services are organised and funded. And I think we need a much better quality of information to face some of the challenges that we have over the next few years.
Thank you very much. Now, we're bang out of time, but I did promise we'd have some questions from the audience at the end, and we will. So are there any questions? Yes, lady over there.
Fliss Murter from King's College London. One thing we haven't touched on at all is governance, and information governance, research governance. I'd like to ask the panel whether they think the information governance and the research governance systems have kept up with some of the technological advances and the data advances, and actually whether that isn't a block in the system, and have they got any suggestions how we overcome those blockages?
Paul Altmann.
Caldecott 7. So I work in an organisation where our Caldecott guardian actually is Fiona Caldecott's guardian, because she's our chairman. And I think that the seventh principle, which has come out of this review that Fiona Caldecott has carried out, is absolutely fundamental. And what it does is to change information governance from a way of stopping things from happening to making it absolutely clear that it's actually about making sure that the right information is where you need it and shared with the appropriate people. It is a block, and it's used as a block by many, many people who actually want a simple way of saying, no, I don't want to play this game.
And did you have an answer to your own question?
Well, we struggle with this because we still encounter the blocks, even though we've adopted that approach, that actually it doesn't need to be a block and it needs to serve what it's trying to achieve and not prevent it. But I think a lot of people haven't heard that message yet, so please let's broadcast it abroad.
I think
Simon,
understanding the systems of what you can do and what you can't do and what's appropriate. I think it's a very murky world out there, and there's too much confusion, and there needs to be more clarity about what is possible and what we should be doing, really, and just using the information.
I don't know how one does it easily in the NHS, which covers virtually all of healthcare delivery in this country, and I'm a huge fan. But in the US, when one signs up to a particular HMO, you abide by their information principles, which may well be, by signing up to us, you do agree that we are going to use your data for research within this organisation for whatever is in your best interest collectively. It won't go outside our organisation, And we don't do that here. It's always an individual discussion. I absolutely understand that. I think that the full Caldecott principle that we're presuming much more than we did will be helpful. But we need a change of dynamic with the public, that the NHS as a big publicly funded body should be aiming to research everything it does at a population level to make it better.
I'd just like to come back on the fact that the NHS is the healthcare provider. I'm in palliative care, and an awful lot of provision is in voluntary sector. There's social care, which actually we need to integrate much more. So I think it's much broader than just the NHS.
Phil Koczan, you wanted to come in.
And I think from my perspective, I work in one of the new academic health science networks, and we absolutely recognise the problems. What we're doing is undertaking a piece of work where we're looking at existing consent, existing data sharing agreements, and trying to get a degree of consistency that we can drive locally between the different organisations, between health, social care, independent sector and research. So at least we've got a common understanding, and then looking at how we can then share that learning nationally.
Thank you, everyone. We've run right out of time. I would like to thank our audience and particularly our panellists, Phil Koczan, Dianna Scarrott, Daniel Ray, Paul Altmann, Simon Eccles, Martin Bardsley. Thank you very much.